Hello everyone and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would like to now turn the meeting over to your moderator, Jessica Fournier, Improvement Lead at Canadian Foundation for Healthcare Improvement. You may go ahead.
Good day, everyone, and welcome to today's webinar. I'm Jessica Fournier, and I'm your host for today's webinar, which is the third webinar in CFHI's new discussion series, Community Dementia Care and Support, Innovations Supporting People Living with Dementia and Care Partners Closer to Home. We are pleased to offer French simultaneous interpretation on today's webinar. If you would like to see and hear the presentation in French today and you have not yet been transferred, you can let us know in the chat box on the bottom right of the screen. Once you have been transferred, you will need to shut down your computer speakers and dial the number on the screen. We also invite you to share your questions and comments at any point using our chat box in either English or French. We will reserve verbal discussion of comments and questions to the end of the webinar, but encourage all of you to respond to comment and answer questions in the chat as you wish as we go along. Also, a note that we will summarize the chat questions and comments after the webinar and translate this to both official languages for sharing in a post-webinar synopsis. The post-webinar email will also include links to today's recording and the slides for today's presentation. Thank you to all for answering the lobby poll question. Our participants for today include representatives from across Canada. We are joined by representatives from regional health authorities, universities, Alzheimer's societies, research centers, Dementia Advocacy Canada, ministries, the Canadian Agency for Drugs and Technologies in Health, CFHI, Health Canada, Public Health Agency of Canada, community support organizations, dementia care organizations, retirement and long-term care homes, CABI, AgeWell, CFN, the Canadian Medical Association, the Royal College of Family Physicians, and government health departments from across Canada, as well as many, many more. Before we go further, I want to begin this webinar by acknowledging that we are meeting on land that has been inhabited by Indigenous people since the beginning. In particular, we acknowledge that I am hosting this webinar from Perth, Ontario, which is the traditional territory of the Anishinaabe, Huron-Wendat, and Haudenosaunee, St. Lawrence Iroquois people. This territory is covered by the Upper Canada Treaties. I encourage you all to share in the chat box the territory and land you are joining us from today. Our CFHI team involved in creating and producing this webinar series includes Tanya McDonald, Jennifer Major, and me, Jessica Fournier. Sheena and Kelly are behind the scenes producing this webinar today. Our presenters today are Dr. Linda Lee, Dr. Claire Liddy, and Dr. Celeste Fung. We also have our session moderator, Jim LaPlante, who will lend his expert perspective to the information presented and to comment on the questions and comments you enter in the chat. I will now turn it over to each of our presenters to quickly introduce themselves. Linda, thanks for being here. Over to you to introduce yourself.
Oh, hi. I'm Carol, the elderly family physician in Kitchener. I'm a Schlegel Research Chair for Primary Care and Associate Clinical Professor with McMaster University, and I'm the lead for VINT Memory Clinics in Ontario.
Thank you, Linda. Claire, would you please introduce yourself next?
I'm based in Ottawa. I'm a professor with the University of Ottawa Department of Family Medicine, and I'm the co-executive director and co-founder of the Champlain-based EConsult service.
Thank you, Claire. Celeste, over to you to introduce yourself.
I'm a family physician who's practicing primarily in long-term care now. I'm the medical director at St. Patrick's Home, which is a not-for-profit long-term care facility with 288 beds. I also have a role with the EConsult Center of Excellence as their long-term care lead in primary care.
Thank you, Celeste. Jim, over to you for a brief introduction of yourself and the expertise and experience you bring to this conversation today.
Hi, it's Jim LaPlante. I'm talking to you from Ottawa. Basically, my wife and I were caregivers to our parents over an elapsed period of 14 years. I have been a volunteer in the executives of family councils here in the eastern region of Ontario. Over a period of 4 years, I was a patient advisor member with Health Quality Ontario, organizing teams that managed 3 provincial conferences on quality transformation. And over the last 4 years, I've been an active volunteer care partner supporting research and implementation of EConsult and working to help with on 2 collaboratives, one on frailty and the other on dementia in the community.
Great. Thank you, Jim, and thank you to all of our presenters for being here today with us. I will now provide an overview of the objectives for today's webinar. So provide an overview of CFHI's Community Dementia Care and Support webinar discussion series, broaden awareness and discuss MINT memory clinics and the EConsult base service, and facilitate a discussion around the potential spread of innovations to improve care and supports in the community for people living with dementia and care partners. So a little bit about CFHI. CFHI is a not-for-profit organization with a mission to collaborate with partners to identify and spread proven innovations to improve healthcare closer to home and community in areas of shared provincial, territorial, and federal priority. The impact of our work is lasting improvement in patient, family, and caregiver experience, and health, work life of providers, and value for money. We believe in the collective power for change, so partnering with others where we can add value is central to our work and vision. Our Community Dementia Discussion Series will broaden awareness and discuss innovations that aim to improve timely diagnosis of dementia in primary care, post-diagnostic supports, including coordination and navigation. To find more information about the topics and webinar dates, you can visit our webpage on the CFHI website. If you know someone who would like to attend this webinar, please send them the link to register to receive the information. If you know about an innovation that could spread across Canada that improves timely compassionate dementia diagnosis in primary care or coordination and navigation of post-diagnostic care and support that would work in COVID-19 context, please email us at the email provided on the screen to let us know. You can contact us at the email provided if you would like to receive a package to help us promote this webinar discussion series through your website or through social media. For your consideration today and throughout the series, we'd like you to think about what are the promising innovations that exist that could be spread across Canada, including in the COVID-19 context. What is the feasibility of your organization and or community to implement and spread the innovations? Where can CFHI add value to support a multi-jurisdictional approach to spreading these innovations? And what are the partnership opportunities to help spread innovations to improve community dementia care and support? For example, group or one-on-one calls that can be scheduled with interested participants. I'd now like to ask Jim a question about what matters to him regarding improving dementia care and supports in the community.
Thanks. I thought I'd just start my very brief comments by making everyone aware that this is World Alzheimer's Month. And it's interesting that we're having this webinar during this month. And for anyone that's not familiar with this, I want to note that September marks the 9th Alzheimer's Month, when Alzheimer's associations worldwide make an effort to extend the reach of their awareness programs and initiatives to educate the public on the impact of the disease on individuals within diverse communities. So it's a significant month for the work that we're all involved in. I just wanted to note that today persons in the community, particularly seniors, are facing the challenges of having to self-manage their health care from 2 perspectives. One, living alone at home with varying levels of access to family, friends, social and personal supports, and health care in the community, and managing their care within the realities of social distancing. Increases in the size of the population over 60 and the impact of COVID-19 have and will continue to impact on demands for the delivery of a modern healthcare system that delivers high-quality care. A local-based focus on healthcare support based on care delivery approaches such as the MINT memory clinics, supported by coordinated community service, is recognized as a model of care of the day. In addition, impacts limiting face-to-face social relationships are and will continue to increase the need to access virtual navigation tools at no cost to the user to support decision-making about care options through care planning. EConsult-based service is an important example of bringing the ability of primary care providers to obtain specialist opinion in a timely and equitable manner to support care planning and delivery. What we are seeing today with respect to the delivery of healthcare as it responds to the pandemic is an increasing emphasis on the integration of healthcare delivery services and a sensitivity to the awareness of providers to the changing needs of care by recipients. Today's discussion focuses on the harmonization of two healthcare delivery services that recognize the importance of using an integrated team approach supported by the principles and practices of patient, person-centered care. In this context, I would ask you to consider and share what matters to you regarding improving dementia care and supports in the community. And finally, I would also ask if you could enter your responses during the presentations in the chat box in both English and French. They will support part of the discussion segment at the end of the presentations.
Thank you, Jim, for those reflections. I'd now like to turn it over to Linda Lee, who will present her MINT memory clinic model.
Hi, I'm Linda Lee. As I mentioned, I care of the elderly family physician in Kitchener, Ontario, and I greatly appreciate this opportunity to share with you more about our innovation called MINT Memory Clinics. MINT stands for Multi-Specialty Interprofessional Team, and this model of dementia care was developed by our team in 2006. It was designed to take the most challenging aspects out of dementia care and to address it at the primary care level in collaboration with the patient's own family physician and with collaboration with specialists and community partners. We act as a hub in primary care to ensure effective communication and to coordinate services and supports throughout the patient journey. It's about compassionate, continuing, complete care accessible from one location close to home. The cornerstone of this model is standardized, nationally accredited interprofessional training for all team members, including family physicians, nurses, social workers, pharmacists, and others. Since 2008, 114 MINT memory clinics have been established in urban and rural, remote, and underserved areas of our province, and now nearly 1/5 of Ontario's population has access to the service. Several of our sites serve Indigenous communities and ethnically diverse populations, including Francophone, Korean, and Chinese-speaking communities. In Ontario, more than 55 specialists support our MINT memory clinics, and we are in the midst of a provincial initiative to establish a dedicated triad of geriatrician, geriatric psychiatrist, and cognitive neurologist to support each of the 114 MINT memory clinic sites using virtual technology with EConsult, and we've been working with Claire Liddy and her group to make this happen. This dedicated, close working relationship between MINT clinics and specialists is expected to further enhance the efficiency and effectiveness of this collaborative specialist support. The fundamental principles of our innovation include standardized, nationally accredited, comprehensive interprofessional team training, a multidisciplinary approach in primary care with real-time communication, collaboration between specialists and primary care with triage of only the most complex conditions for specialist input, and most importantly, continuing comprehensive person-centered care that is individualized and inclusive of the needs of care partners. The adaptable principles of our innovation include the method of specialist integration, whether that be virtual or by telephone or in person, and the integration of local and regional community supports, which is very dependent on available resources. Our program was developed with patient and caregiver input throughout. Let me give you an example. Most recently, we needed to develop a process to help clinical researchers recruit participants from our MINT clinics for research studies. The question was, how can we do this in a way that is ethical, sensitive, and respectful of the needs and preferences of persons living with dementia and care partners? So here we are, last fall, me with several team members representing MINT clinics across the province and leading experts in geriatric medicine, geriatric psychiatry, and cognitive neurology who support our clinics, all of us meeting at Ontario Brain Institute in Toronto. But most importantly, we are connected by video conference to a meeting in Kitchener, around 100 kilometers away, with 13 members of the Waterloo-Wellington Dementia Advocacy Group, both patients and family caregivers. They started off our meeting by sharing their perspectives on how our MINT clinics should be recruiting for clinical trials, when to ask, how much information to provide, what they want and don't want, and this set the framework for the creation of a truly patient-driven method of recruitment that is sensitive and respectful of patient needs and preferences. We asked them what they wanted, and then we tried to create a process to achieve this. Once finalized, this process will be rolled out across all of our MINT clinic sites. There are positive health system impacts associated with MINT memory clinics in Ontario. A recent independently conducted provincial evaluation found that in comparison to usual care, MINT memory clinic care was associated with fewer and shorter hospitalizations and emergency department visits, delayed institutionalization by nearly half a year, and substantive reductions in healthcare system costs. The evaluation researchers estimated that persons receiving care in our MINT clinics cost the healthcare system almost 40% less than usual care. This evaluation was commissioned by the Ontario Ministry of Health, independently conducted and overseen by Health Quality Ontario, incorporating extensive administrative level data from Institute for Clinical Evaluative Studies and involving 180 stakeholder interviews. Their evaluation also confirmed our previously published findings of referral rates to specialists being reduced to less than 10% as compared to their findings of 100% referral rates to specialists in usual care. By reserving referrals to specialists for only the most complex of conditions and close partnerships with our specialists, this model builds healthcare system capacity to better meet the needs of our aging population. COVID-19 has brought to the forefront the need for better care for persons living with dementia in the community. As highlighted recently, 80% of COVID deaths have occurred in long-term care, and 80% of long-term care residents have dementia. We need to do much more to help persons with dementia remain living in the community, in their own homes, and out of congregated settings, such as long-term care and hospitals where the risk of infection is highest. As the provincial evaluation suggests, by delaying transition into long-term care, MINT clinics can help to achieve this goal. During this pandemic, our team continues to help patients and caregivers using physical distancing, plexiglass barriers, face shields, and virtual outreach where appropriate. Patients and caregivers have been very grateful for the support that they've received in these challenging times. We estimate that 26,000 patients and at least an equal number of caregivers have received MINT clinic care in our province to date. Several evaluative studies have demonstrated very high levels of patient and caregiver satisfaction with services provided in MINT clinics across our province, regardless of whether persons live in large cities or very rural and remote communities such as Temiskaming Shores or Kenora in northern Ontario. I should mention we are a nonprofit organization and all services are fully covered by provincial health insurance. This model is ready to spread to other provinces, and with adequate resources and infrastructure support, we believe that equal access to this model of care is achievable for communities across Canada. With evidence of improved patient and caregiver experience of care, improved patient outcomes, improved healthcare provider experience of care, and lower cost of care, MINT clinics are achieving the quadruple aim. We have been working with a health economist at University of Waterloo on financial modeling, and our preliminary work suggests very high return on investment, and we hope to release this soon. And some exciting news. Canadian Frailty Network recently announced an investment in MINT memory clinics, which will allow us to spread this model to first sites in 2 provinces outside of Ontario beginning in spring of 2021. We are so grateful for this support and for the support of many other organizations that have allowed us to spread this model across our province. Thank you for this opportunity to share our work. Happy to answer any questions. I see there's a poll here.
Great. Thank you, Linda. That was a great presentation. We would now like to ask our participants a few questions about MINT Memory Clinic. Would you like to participate in a call with CFHI to learn more about the MINT Memory Clinic model? Prior to this webinar, were you aware of MINT Memory Clinic model? And I know more about MINT Memory Clinic model than I did before participating in this webinar. So we'll just give a couple of minutes for you to answer those poll questions. You can also, I invite you to type any questions you have about the MINT Memory Clinics into the chat box, and we will address them in the Q&A portion of our webinar after our next presentation. Okay, great. Thank you for answering those polls. We'll now go back to the presentation. I would now like to hand it over to Claire and Celeste for their presentation on the EConsult base service. Claire and Celeste, over to you.
Great, thank you everybody. So Celeste, I think I'll start and then I'll hand over to you for the long-term care data. Hopefully that works. And I think you have given me control. All right. All right, and off we go. So I'm going to talk about EConsult, which is a program that is now implemented across Ontario, and you'll see in several other provinces as well. It was started by myself and my colleague, Dr. Keeley, in 2009 as a small research idea and an innovation, which we then subsequently have grown over the last 10 years. It offers basically electronic access, and I'll go through it, to many different specialty services, and I've got the list, but today some of the data that I'm going to show is really going to be focused from our residents in long-term care, and as Linda had indicated, many of whom are affected by dementia or people living with dementia. So just to hone in on what the issues are, and really the reason why we started EConsult was all about poor access. And at that time, it was actually a patient of mine who, in fact, was waiting for a non-urgent appointment to see a specialist endocrinologist for diabetes care. So I always like to start with highlighting what the access issues are, because the reason for creating EConsult, which is a very simple communication platform between a primary care provider and a specialist, it's to try to get more rapid access to specialist advice than the long wait times that we have. As I said, at that time, certainly it was 6 to 9 months for that non-urgent appointment. So if you focus in and we think about the ability and the challenges associated with getting specialist advice and having face-to-face visits for people living with dementia, there certainly are many hurdles. And we have been working with our patient partners and family and caregiver partners for several years on EConsult, and that has been instrumental, I think, certainly for myself, to better understand the environment and understand some of the challenges with having those face-to-face visits. And in times of COVID-19, certainly it's that people really do not want to be having a lot of hospital visits and specialist visits if it's not necessary, and perhaps you could get that care in another way. So that's really what EConsult is all about. It's simple. When I wrote the grant with Erin, it was actually on the premise of email. So if you think about that, that's really all it is, a very simple way of enabling and helping communication about a patient's case and challenges to any number of different specialty groups. So now it is built on a web portal that ensures that you have privacy requirements met, but it's, as I said, a very simple communication. And it's asynchronous, which means that instead of me trying to, do a phone call, which I often will do when needed, I'm not trying to schedule a time. So what you see here is just a very simple depiction of the requesting provider, who in this case is the family doctor or nurse practitioner, who is able to send on a request to a specialist, and it could be a specialist in many different areas, and I have a list that I'll show you that are very relevant for people living with dementia. And they get an answer back, and what we tried to ask was, could you please try to answer this question and give advice one way or another within 1 week. And you'll see from our results again that often the response is much more quickly than that. We've done a lot of research over the last decades and have been able to demonstrate that it does provide faster access. There's certainly some really interesting improvements in care coordination, mainly because the care and a lot of the advice can then be carried out by your own primary care provider. It has helped build relationships between primary care providers and specialists. And the other piece that's very interesting is it certainly prompts learning and is helping to build educational capacity in different specialty areas between primary care and specialists. So this is a pictorial of how it works, and imagine the key thing here is that this is a conversation that's provider to provider. So I'm a family doctor. You'll come in and see me, and often, or I'll be visiting you, home visit or long-term care home, and we'll have an issue or a challenge. So wondering, for example, about memory issues, any kinds of challenges with medication, caregiver needs, anything, and that could prompt us to have a discussion that maybe we need to have a specialist visit. So instead of me initiating a face-to-face referral request right away, which, as I said, if it's not an urgent or emergency, can take several months, then we can agree that I'll initiate an EConsult. So I'll go on to the system and basically put in the information that we had talked about. I can put in images, videos, case information, anything that's deemed relevant. I can put in, your questions as well. And then usually within a week, I will hear back some kind of advice from that specialist. Typically, this is a brochure we give to the patients and their families, so that usually I will then communicate with you within 2 to 4 weeks. It's faster than that, but this is just to set the expectation and have a discussion with you about the type of advice that was given. And if it's appropriate and still needed, or it is suggested a face-to-face referral is needed, then at that point in time I would initiate that. But many times the advice that I will get as a family doctor actually helps me then carry out some action with you, and it may in fact avoid a face-to-face visit, or I might be directed to the most appropriate specialist for you. So you can imagine, for people who are living with dementia, perhaps in the diagnostic phase, as Linda was saying, if you're being assessed at the memory clinic in Ontario, then if there's anything that needs to be basically looked at further, you would be able to access many of the specialists through the EConsult service in Ontario. And again, like Linda, we don't have a company on it. It's just a service that a model we created, which is now being run by and funded by the Ministry of Health in Ontario, and also, as you see, in many other provinces. So I'm also a health services researcher, and we did get several national level grants where we've been working with a variety of provinces. So this is a snapshot. I noticed that there are some folks from Saskatchewan. I think we've got Alberta on the line, New Brunswick, Nova Scotia. So in Ontario, New Brunswick, Newfoundland and Labrador, and Alberta, there's an EConsult type of system which is available province-wide, funded, paid for by your Ministry of Health in a variety of different ways. So in Alberta, it's called e-advice. In Ontario, it's EConsult, and EConsult basically in the other provinces as well. So if you're wondering, I wonder if dementia services or geriatrics is available on our EConsult service, or does the province actually have it? In those provinces, it is funded as a full provincial program, and I'm happy to follow up with you with more detail on that. Manitoba and Quebec are both in negotiations. I think Quebec a little further along, but they will be also implementing a full program. It's available in several regions right now, just as an early pilot or proof of concept. And in Quebec, they are going to be and are looking at integration with the full e-referral. Manitoba is available in pockets, and again, it depends on, some of it is still funded through research grant funding that's coming from our team. British Columbia has a variety of services available too, and it depends on which region you're at and what the funding is like. And finally, I highlighted that Nunavut, there is available services for EConsult, and the government of Nunavut is in partnership with our team here in Ottawa. I'll move on, and if you have other specific questions on your region, I'm happy to follow up with that. So I've just got a snapshot of what the Ontario eConsult program looks like, and it's hosted now through the Ontario Telemedicine Network, Ontario Health, and again, all primary care providers and specialists can get accounts for free, and specialists who are participating in the program are remunerated, they're paid to give the advice by the Ministry of Health. This is a snapshot of the types of specialty groups that are available. So the very neat thing about this model is that it doesn't require you as an individual family doctor or nurse practitioner to know, who is the geriatric specialist, or how do I access memory clinic care, what about geriatric psychiatry. So we have them all set up as specialty groups. And then what you're able to do is access the specialty group, and as soon as you enter into the conversation, then you have visibility of who the specialist is. And as much as possible in Ontario, we've built up local communities of practice. So if you're in Linda's area in Waterloo and you initiated an eConsult for geri-med risk, medication, geriatrics, you will be getting the advice back from a local provider. And as much as possible, we've tried to do that, as I said. But in some areas, not everybody has access to that. So the very neat thing about having a model like this, which is specialty-based, means that on a regional or a provincial basis, you can have a limited number of specialists who will agree to provide access across the whole province, and that's the case in Ontario. Newfoundland also has that type of model, so it's very helpful, especially in specialized services needed for people living with dementia, because there's very few providers who might have that expertise. I'm going to hand over to Celeste. Again, this is a small snapshot of our long-term care data. The numbers in Ontario, in the last quarter, 25,000 people who've had an eConsult across a variety of different specialty areas, and this data now is pulling out some of our results, and we have survey results from the long-term care environment, which would be highly representative of the type of access that you can provide for people living with dementia. So over to you, Celeste.
Thank you, Claire, and thank you to the organizers for inviting me to participate. I think the data that's come out of long-term care is really reflective of how valuable this service is. I think that the value of community approaches to try to allow individuals to remain in the community as long as possible, given their advanced frailty, remains the key. However, our long-term care population is really also very reflective of our most frail and most vulnerable, and allowing increased access to specialist advice can be incredibly valued for allowing patients and their families to be more informed with regards to decision-making around treatment plans. So there's two charts here. At the end of any kind of eConsult, the provider is asked to fill out a mandatory survey just to reflect on the advice that they received. Here, this is our data that comes out of our primary care providers who have asked a question with their primary location indicated as being long-term care. And you can see that in 41% of instances, a person is able to confirm a course of action that they originally had in mind by asking a specialist for their advice. And then actually in over 50% of cases, they're actually getting advice for a new or an additional course of action. And so, I mean, that's a really incredible number that, you know, in the absence of being able to ask that advice, they may not have pursued a different action than what they had originally in mind. And so being able to gain access to that type of advice in a timely way is very valuable from a primary care provider point of view. And then when you look at sort of referral avoidance in some instances, you see that 67% of the time, individuals in long-term care, there was original consideration to initiate a referral, but it could be avoided based on the response that they received and the advice they received on EConsult. And then, you know, there are some instances where referral cannot be avoided, and the EConsult service is not meant to be a service to replace in-person consultation, but perhaps may provide a bridging gap and a little bit of early triage for some specialty services to allow the primary care provider to take some direction prior to initiating an in-person consultation that may still be required. And then you can see that also in 2% of instances, referrals were not originally contemplated, but EConsult resulted in a referral being initiated. So there is a safety element to some of these questions being asked that it may alert a primary care provider to an issue that doesn't, in fact, require more thorough in-person specialist follow-up. Next slide, please. And so these are the benefits to the patients and their care partners, the access to specialty services. This is particularly important in rural settings where you may not have access to a specialist within a reasonable distance. And so not only having to contemplate extensive travel, but a long wait time in order to get a question answered, EConsult can help navigate that. Our specialists are asked to respond to questions within a week, but our mean response time is actually 2 days, and there's been instances when I've used the service where you can actually get a response within a day. There's no cost to the patient or the provider to utilize this service. Claire already mentioned the secure nature of the platform and the efficiency of allowing the primary care provider to be able to have more information to provide a treatment option to the patient and their care partners. Next slide, please. And so, you know, this is a highly satisfactory service for providers. These are some of the feedback that we've received. I think when we look at dementia care, whether it be in the community or in long-term care, we know that there's a huge variability in how people present with their dementia. And oftentimes that variability requires a very specific approach, specific to that individual and specific to that individual's circumstances. And the benefit of EConsult is really being able to ask those very specific questions and get a specific response in return, which is much more valuable, I think, to the provider, the patient, and the caregivers. So with that, I'm going to hand it back to Claire, I think, for this section.
Thank you. Yeah, we'll wrap it up. So we've, as I said, there is, again, similar to what Linda was saying, you know, we've taken a quadruple aim approach on evaluation, and this just gives a snapshot of the effectiveness and across all 4 aims. And I have a lot more detail behind this, but I think the biggest thing that we've seen, as Celeste said, in long-term care is the appreciation of the provider, family, and the patient, the residents themselves in terms of the rapid access to the advice. And it's not intended to replace a face-to-face visit, but in many cases does end up giving treatment advice and allowing your family doctor or nurse practitioner to start care while you're waiting for whatever might come next, so very tailored care. I think Celeste has spoken about this, but I think that the biggest thing that I wanted to message, and you know, the work that we've done more recently, was we thought that it was too complex. These types of questions and cases and referrals would be too complex for this type of communication, and I think what we've demonstrated is that that's not the case. And in particular now in COVID-19 days, it's even more highly valued. And really, again, because the rapid advice, excellent for rural areas as well, and it does save a huge burden of traveling. We have a lot of tools that are available, so I'm just highlighting a couple of them. If you're wondering about fact sheets, we have frequently asked questions. Use case examples I put here. These are our infographics that we've created, and they are all available for you to take a look at on our website. And then also usually get asked about liability. So CMPA has been a partner with us since the very beginning. And as I said, we've what I had shown you at the beginning was a patient pamphlet. So lots and lots of information there if you're wondering sort of about how the model works. The neat thing is that it can be essentially implemented, and it has been implemented on all sorts of different technology platforms, ranging from electronic health record in Alberta and New Brunswick. Newfoundland has also gone that model to a standalone web platform. That's what we're using in Ontario right now. Manitoba and Quebec is going to be integrating their model into their full e-referral platform. So all sorts of different ways. BC has some interesting mobile apps that are available, and also some work that's being done in Alberta where it's linking this type of a system and approach with also specialist link or rapid access to consultative expertise, which is the telephone access service. So again, happy to answer any questions, and again, we have a lot of information and happy to share any information that you need. So if you're in a province that already has EConsult, then the question to ask is, do you actually have your specialty services that would be relevant for people living with dementia offered on the service? And if not, I would encourage you to get them on board. Thank you. Thanks, Celeste, for your help with this, and again, we're here to answer questions.
Great. Thank you, Claire and Celeste, for your great presentation. Well, we will now turn it over to our participants to answer some more polling questions. I'll read these out for everyone. Would you like to participate in a call with CFHI to learn more about the EConsult-based service? Prior to this webinar, were you aware of the EConsult service? I know more about the EConsult-based service than I did before participating in this webinar. We'll give a few moments for people to fill out this poll. I also encourage you, if you have any questions for Claire and Celeste, to please type them in the chat box in either of the two official languages. I've seen some questions coming through. We are keeping note of them, and we will answer them in a few moments when we get to our Q&A portion. If we do not get to answer your question during this webinar as time permits, we will follow up, as I said earlier in the webinar, with a webinar synopsis where we will have all of the questions and answers. Okay. Thank you for filling out the poll. I will now turn it over to Jim to offer a few reflections on what he's heard today. And maybe I'll ask the question, Jim, what opportunities do you see for us all to work together to implement the National Dementia Strategy?
Okay, that's certainly a very broad question to reflect on. I just wanted to start by spending just a moment or so about the experiences that my wife and I had with both of our mothers. And this was our experiences starting, although growing a little dim, it is not leaving our consciousness in terms of the impact that their dealings with Alzheimer's and dementia had on them and on us. Very quickly, what was interesting back then is that we spent a lot of time and had support on the assessment end of their care, looking at dementia, vascular dementia for my mother-in-law, and looking at Alzheimer's for my mother. But once we got through the assessment phase, our recollection and kind of our bitter memories are that we were generally left on our own to seek, support with respect to the care for both our mothers as they moved through the healthcare system, particularly as they left their homes to kind of intermediate care and moved on to long-term care. What I'm finding interesting is that COVID-19 and the wave of COVID-19, the wave of the disease, is making me and my wife more alert, to, the impact that this disease is having on two things. One, because of social isolation at home, and the other one because of the whole issue of separation. I mean, we're looking at an aging population now that is faced with dealing with not just assessment, but support, as I mentioned in my opening remarks. And so, what I have learned from these two presentations is that because of the awareness that we have with COVID-19 and the impact of COVID-19, MINT, the MINT initiative and the EConsult initiative is providing, if you want, that support that we never saw in the past. And it's doing it from two perspectives. One is it's focusing on supporting patients or persons and their caregivers in the communities through an integrated team approach. And secondly, it's responding, if you want, to the move away from face-to-face care to virtual care. And so, what I've heard from the two presentations is from, an awareness of what's happening around us. People will not be faced with the kinds of issues that we dealt with well over 6 years ago, which was, taking assessment information and then going on a very long journey, to look for support. So these two examples today, I think, can give us all a great deal of hope. I think for the fact is that there's a number of varied approaches to provide, support to dealing with both Alzheimer's and dementia as we move forward into the next, wave of COVID-19. So that's what I've learned from today, and I continue to learn from the work that I'm doing with CFHI.
Thank you so much for those reflections, Jim. I've now had a lot of questions come through the chat box, so I will start asking our speakers to address those questions. So one question that came in is the evaluation of MINT publicly available? And thank you, Linda, for sharing the link to the evaluation in the chat. Then another question was, the presentation mentions education for MINT team members. What education programs are provided? And Linda kindly responded in the chat box that the MINT Memory Clinic educational program is a package consisting of 3 days of workshop training and 2 days of on-site mentorship, designed to help sites establish fully functional interprofessional MINT memory clinics. In our experience, to achieve these outcomes, we feel it is important that all aspects of the program be delivered. So one question for you, Linda. Who determines locations for MINT clinics? And also, is access to MINT clinics limited to members of family health teams?
That's a great question. So to date, it's been determined based on willingness to establish a clinic and also funding. We have been grant to grant as a nonprofit organization, and wherever we're able to get funding, that's where we train. So it has been based to some extent in those ways, and where we have a region that we can train, we try to engage persons in the system who know their local community best as to where this model is most needed. For example, in some of the northern parts of our province, we engage the regional geriatric provinces and programs and the LINs to help find the sites that were most in need. So it's based on funding, availability, interest for sure, and so it's a kind of a combination of who is really interested in having this done and where can we find the funding to support the training. With regards to, is this limited to family health teams? No, absolutely not. These clinics have been established in every primary care practice model in our province. So that's family health teams, family health organizations, CHCs, and in fact there are several that are regional clinics which are open to the entire community. There's several of those as well. So it's not limited to a particular practice model.
Great, thank you for that answer, Linda. One question that we had for Claire was, if a territory wanted to establish a funded EConsult program to support dementia care, what steps could they take to start those conversations? How might technology and language barriers be an issue?
Well, it depends on which territory, because some of them have already done some work. So as I said, Nunavut, our team is already in discussions with them and providing service. And then, so again, if there's other territories, then I could speak to that in terms of the what's already happened there. For example, Northwest Territories does have a full electronic health record and have the capability, and I think are already doing some kind of e-consult within that. In terms of the language piece, I guess I'm not quite clear if the e-consult is right now based in English. We do offer French language services. Other languages, you could have a specialist that, if they have the ability, could answer that back. Again, this is a provider to provider, so we would rely on the interpretation, I guess, of the results in the discussion back with the primary care provider and the patient or the family. In which case you could use, I guess, interpreter services as needed. Again, a bit of a broad question. The technology piece is irrelevant in the sense that the system and the ability to implement an e-consult is based on having a secure private network that enables patient health information to be transferred back and forth. Because it's not synchronous or dependent on video, the capability and sort of the bandwidth, you don't really need that much because, again, it's not happening in real time.
Great, thank you, Claire. For Linda, how did you measure reduced or delayed admission for LTC for MINT patients?
That's why I posted the link to the evaluation itself. I wasn't involved in conducting the evaluation. It's completely done independent of me by a third party commissioned by the ministry. So you can read through that very lengthy report, and I think they've described some of their methodology there.
Great, thank you, Linda. One question that I did see come in through the chat for Claire was, how does the advice received become part of the legal documentation record chart from specialists? And Claire kindly responded in the chat box that e-consult transcripts are either added into the record by the primary care provider. In some systems, this is either manual, done like any other document, or automatically integrated. So thank you for responding in the chat box, Claire. For Linda, there's a question about, do you address all aspects of patients' health, including social and emotional health, etc.?
That's our aim, absolutely. In fact, I've been reading through some of these messages, and it's hard to keep up with all of them. There is, for sure, an emphasis on the care aspect for both the patient and the family care partner. We recognize that after an accurate, timely diagnosis, it is about care. How do we help persons to live with this condition for as long as possible in the community with best quality of life? And that very much involves care for the patient and for the care partner. So every visit is about 2 people at least. Care partners have an opportunity to speak with our team, our social worker, privately at every visit. It's a team-based care for the patient and family. It's about more than a diet often, and incorporating their preferences and values and goals at every stage. It's continuing care from a team that they learn to trust and rely on and has the expertise to meet whatever comes. And it's about helping them to live with quality of life. There's this question about pieces as well. Absolutely, pieces is integral to the training that's incorporated in our program. And this question about psychologists. About 3 sites have psychologists embedded in their teams. The team member complement is one of those adaptable principles where it depends on who is available and what resources are available, what team member resources are available. Many come from the community and many come from the primary care sites as well, and it varies. Every site across the province is a little bit different. Some of the sites have psychologists that were funded through their the primary care organization, the family health team. Some have psychologists that are funded through hospitals that participate in our model.
Great, thank you, Linda. We have about 5 minutes left of the webinar, so we're at time for the questions and answers. But as I said earlier, we will make sure that we've written down all of the questions that you've asked in the chat box and provide answers in the synopsis that we send out after the webinar. So I want to thank all of our presenters today for participating in the webinar, and thank you for answering the questions that have come in. I do want to take this time to let you know about a program you might be interested in. So to help support the long-term care and retirement home sector to rapidly share with and learn from each other and strengthen pandemic preparedness, CFHI and the Canadian Patient Safety Institute launched the program LTC Plus, Acting on Pandemic Learning Together. LTC Plus is for teams delivering healthcare to older adults in congregate settings, and registration is open. Joining gives teams access to national huddles, one-on-one coaching, and seed funding to go towards strengthening pandemic preparedness plans. You can get more information on our website, and I'll pop the link in the chat box now. I would like to thank Linda, Claire, and Celeste for their presentations today. I would also like to thank Jim for his thoughtful reflections and comments. Thank you to our producers, operators, and simultaneous interpreters for their efforts in making this webinar happen. Finally, thank you to all of you for joining us. We will now move to a couple of CQI questions, and your answers to these questions help us plan our future webinars. We'll just pull those up. And I'll read out the questions. So overall, I was satisfied with my webinar experience. Overall, I was satisfied with how I was able to actively participate in the webinar. And do you have any other comments or suggestions to improve the content shared in this webinar? Once again, thank you for joining us today, and we wish you a great rest of your day. We'll see you next month for our October 20th webinar.
Ladies and gentlemen, this concludes today's conference call. Thank you for participating. You may now disconnect.